Sometimes the problems with the passageway can be determined at that early prenatal visit when the healthcare provider puts a glove on and goes in and feels for the ischial spines, pointy ones that are going to possibly hang the baby up, and feels the depth and the width of the pelvis. But again, many times that's not diagnosed until the patient's in active labor. Cephalopelvic disproportion, big fancy words. Cephalo, head, pelvic, mommy. Disproportion means they don't fit. And that is so closely related to failure to progress. It's hard to tell oftentimes which one is the real problem because they go together. The baby won't come down the birth canal, or it will fail to progress if the pelvis is too small or the baby is too big. So it's hard to say which is the bigger issue when labor doesn't progress. So that's the passageway. And then there are all those lovely soft keys, ones that I like best. And that's why I firmly believe that the support person, the information the patient gets ahead of time makes such a tremendous difference with the woman's ability to be able to relax and work with her body, to be able to visualize the cervix dilating and letting her body do what it needs to do, not fighting the contractions, which is natural because they hurt, but just letting go and letting birth go the way it is meant to go. Did any of you see any doulas with laboring patients so far this semester? Yeah. They do have doulas at Chase Grove. I haven't seen any on the days that I've been there either. Doulas are sometimes nurses, and they are oftentimes lay people who have had special education and training. And their job is not to provide nursing care. Their job is to provide physical and emotional support to the laboring couple. Sometimes they're in place because maybe the support person has a job like a fireman or a policeman, or maybe in the military where they may not be present at the time of the birth. And sometimes they're just there because both people want to have another person who's there as their advocate and to help them deal with the work of labor. But the doula doesn't do nursing care. The doula isn't changing pads or watching the Pitocin or anything else. The doula is strictly there to be a support for the couple that's in labor. And it's a neat thing that a lot of nurses choose to do when they're not working as sort of an on the side. That, like being a lactation consultant or teaching childbirth classes, are some of the things that OB nurses do in addition to their 12-hour shifts in the hospital. You need to know that there is that hormone cascade that gets going when the fight-flight hormones, which are the catecholamines, are in high measure, that they actually block, they along with the stress hormones, actually block the work of labor because they knock off on in the receptor sites the natural Pitocin that a body has, or oxytocin. Let me explain that a different way. When you are in labor, your body is secreting oxytocin. The woman's body is doing that to make her uterus contract when she went into labor on her own. But if she has a high level of the stress hormones, the fight-flight bad guys, it actually blocks and knocks off the oxytocin off the receptor site. Remember back to 110 when things could bump other things off? Like birth control pills can be bumped off with the use of antibiotics? Okay, same kind of principle. So the emotional support for the nurse who is in labor and delivery is very important. And I think you have probably had the opportunity to see nurses who do really well, and some nurses who are more, maybe they're a little bit burned out at what they're doing. Maybe they're spending more time at the desk than they are in the patient. And then we've seen a little bit of that, I'm sure, in different clinical sites. That unfortunately happens. And again, I'm back up on my soapbox. And that is that nobody should be doing nursing that they don't really love or enjoy. If it's not giving you positive feedback every day, look for something else. But there's so much to do in nursing. Nobody should be doing angry for our profession. Post-term pregnancies are pregnancies that go past the 42nd week, and statistically, it's about 10% of all pregnancies. In real life, most of the time that people would be post-dates if they were allowed to wait until they were in labor is because their pregnancy is incorrectly dated. So let's look I know we're not going to be testing over menstrual cycle this time, but you still have to understand it, because if you ovulate mid-cycle and you have a 28-day cycle, you're just like clockwork every month, your due date is going to be pretty accurate, correct? However, if you have a menstrual cycle that's 21 days this month, and it's 34 next month, and 45 the following month, and then it's 19, how are we going to figure out from your last menstrual period when the baby is due? It's going to be really tough. Ultrasound, if you've had that early ultrasound, that would be ideal for dating. A lot of people don't get it for many reasons. Cost, moving around, entering prenatal care late, whatever. So sometimes pregnancies are dated as being post-dates, when in real life, when the baby comes out, it's not post-dates. It's got a lot of vernix on it, which goes more with a baby that hasn't been floating around in water past its due date. In this country, again, it is rare to see a woman coming in labor at 42 weeks. And why is that? Because the risk of that baby having a bad outcome going past the due date gets higher and higher. And one of the biggest issues is that the placenta is not working as effectively as it's really post-dates. The placenta can start to shrink, start to atrophy, and then it's not nourishing the baby the way it needs to be. So the risks for mommy and baby are listed here. Sometimes there seems to be a thought that the reason a woman doesn't go into labor spontaneously on her own is that there's some kind of underlying problem. And we really don't know. If this is 2013, we really don't know positively what makes labor start. You know, we know, though, that it's not just all about the mother, that there's a close interrelationship between the fetus and the hormones it secretes and the mama and her hormone status. Maybe in your lifetime, guys, you'll know exactly what makes labor start, but you don't know right now. But going post-term means that you have a bigger baby, so more risk of birth trauma. More risk as you go past the due date with the placenta not working as well, and less oxygen, but the baby will have his first bowel movement, meconium, into the amniotic fluid. And once it does that, that raises the risk that the baby can inhale those little tiny flecks of meconium and have an aspiration pneumonia. Bad thing. I don't know how many of you had a chance to see NICU, but some of your sickest babies in NICU, because you're big babies. Not just diabetic babies that are LGA, but big babies that were at term or post-dates that had meconium aspiration and have really major respiratory problems and are on ventilation. Another risk for babies that are post-dates is brachial plexus injury. I'm not really talking much about babies today because next week you're going to be hearing all about preterm babies and sick babies from Professor Dr. Cooper. But a baby that came out with shoulder dystocia, what do you think might be a problem for that baby? Clavicle can break in the efforts to get that baby out. And that's not a big deal most of the time because the clavicle heals pretty nicely. What would your signs and symptoms be of a fractured clavicle? Okay, you're saying, Abraham's saying crepitus here when you palpate over the clavicle. One other thing. Well, it's hard to tell babies in pain, but possibly. I'll give you that. One other biggie. Melissa?
Depression? Like one side's lower than the other?
Possibly.
Doesn't it chop out?
No. One leg is short. Erb's palsy, or brachial nerve plexi, where the arm doesn't move. So you see a baby that's eagerly sucking on its fist like this, and the other arm is just laying down by its side. And you go to do the Moro, and the baby has the startle reflex, but the other one doesn't move, or moves very little. So unequal upper body movement, which is a big umbrella term for what we're talking about, would be another clue that the baby might have a fractured clavicle. It would raise your suspicion. I think of all the things, the one that I think is probably the most important, although they're all important, is the potential for the uteral placental insufficiency. you've seen on the monitor strip, presents as what kind of acceleration? Late, which oftentimes ends up in being a cesarean, right? The assessments that are done for post dates are, well, first of all, to get dated correctly, we hope there's an early ultrasound. But once you're getting close to term or post dates, the healthcare provider is usually having them on and do fetal movement counts. She may be coming to the office or to the hospital, depending on what their office setup is, to have non-stress tests. What happens in a non-stress test again? She's got the fetal mode, she's got the fetal monitor on her, correct? And, say again, Ryan?
I think they eat some food and they monitor the movement of the fetus.
Well, we don't want her to be hungry. If it's mealtime, you know,
But I
yes,
thought
we can
that
get her a
stimulated
snack.
the movement of the fetus.
If we can give her some juice or some ice water. Okay. And what do we want to have happen? What, you're giving the instructions to the mom. What are you telling her to do? Push a button when what? When she feels. Feel movement. Okay. And then what do we want to feel on her strip? Acceleration. How high? How long? 15 by 15. Yes. Okay, you got it. So we want to see that because that lets us know that the baby is probably well oxygenated and it's hopefully neurologically intact. That's what we're looking for. Maybe having biophysical profiles too. Healthcare provider's going to start examining the cervix to see how inducible, how likely is she going to go on to labor on her own. And ultimately, the physician or the midwife and the patient are going to talk about whether or not to induce if she's going very much on those dates. Which leads us to our next topic, which is Pitocin. Yay! So, we have two descriptions here, augmentation and induction. And induction says that we're using a medication to stimulate labor prior to the onset of labor, a spontaneous onset. And augmentation is used to make the contraction stronger, more powerful, more effective, get the show on the road, get delivered if they're not coming nice and regularly. So here is a question for you. Mother comes to the hospital, she's not having any contractions at all, but she's admitted because the membrane's ruptured. Is that augmentation or induction? I'm going to ask for a show of hands. Think about it. And then I'm going to ask, how many people say it's induction? Okay, and how many people say it's augmentation? And a whole lot of non-voters here.
Get in here.
The scenario, again, listen carefully. You can hear this in another form another time. Patient comes to the hospital. She's not having any contractions. Her membranes are ruptured. They're going to hand Pitocin. Is it induction or is it augmentation? Okay, it is augmentation. Labor started because her membranes were ruptured. So she spontaneously started with labor even though she's not contracting. Okay. Has everybody had an opportunity to see Pitocin running? Yes. All right. So we're gonna talk about the other drugs that are used and then we'll come back to Pitocin. Sometimes when it's medically necessary to induce labor, the cervix is not right. What do I mean by right? We like that cervix when labor starts to be soft, to be thin, to be stretchy, already starting to efface, right? Because she's going to make faster progress if it's that way. But let's say she has gestational hypertension or she has diabetes and the baby's big enough already and they've checked to make sure the lungs are mature and they say, this baby's going to be better delivered now than waiting. There is a chart in your book that is called the Bishop score, and I think it's around page 6.